On TOLOSA hint. Good morning, everyone. I'm Gladiss from Medicine 2, presenting TOLOSA hint. This is a case scenario of a 60-year-old gentleman who presented with complaints of diplopia and pain over the right side of face since one day. He was apparently well till a day back when he developed diplopia for the vehicles in the road when he was traveling in a two-wheeler. It was associated with a right-sided frontal headache and right periorbital pain. The next morning, he noted right-sided complete drooping of eyelid. There was no history of decreased vision, no history of facial deviation, hearing difficulty or swallowing difficulty, no history of limb weakness, and no imbalance. He's a known diabetic on OHAs in the last 10 years. Personal history and family history were normal. On examination, vitals normal, general physical examination is normal. Central nervous examination showed higher mental function normal. Cranial nerve examination showed right cranial nerve third palsy with bilateral pupils equal and reactive to light. However, there was no loss of vision. The visual acuity was normal and there was no involvement of other cranial nerves. The sensory system examination was normal. Cerebellar signs were absent. Skull and spine normal. The other systemic examination findings were normal. So to summarize, a 60-year-old male who's a known diabetic with a syndrome of pain in the right upper half of face with diplopia, drooping of eyelids, and on examination, right cranial nerve third was involved without pupillary involvement.
Slide. Present, right under it. On. Play. Agree.
Thank you for the response. So the anatomical localization of the syndrome, the third nerve nucleus situated in the midbrain, the fascicle, the subarachnoid space, and the lateral wall of cavernous sinus, the superior orbital fissure, and the orbital apex were considered. If the nucleus of the third nerve in the midbrain was involved, it would result in an ipsilateral third nerve palsy with a contralateral superior rectus weakness because of the crossed fibers which supply the superior rectus, and bilateral ptosis because of the central subnucleus involvement, and the fascicular involvement presents in three syndromes: Weber's with contralateral hemiparesis, Benedict's with contralateral tremors, and North-Nagel syndrome with ipsilateral ataxia. Both nucleus and fascicular involvement have similar pathologies like infarction, hemorrhage, and tumor. If the subarachnoid, if the cranial nerve third is involved in the subarachnoid space, then it would result in an isolated cranial nerve third palsy and occasional headache and orbital pain due to internal cerebral artery or posterior communicating artery or basilar artery or posterior cerebral artery aneurysm or microvascular ischemia in case of diabetes. If the lateral wall, if the cranial nerve is involved in the lateral wall of the cavernous sinus, then it would present with cranial nerve 4, 6, ophthalmic and maxillary division of the fifth nerve, along with Horner's syndrome, and pain may be present. Here again, the pathology involved would be tumor, inflammation, or diabetic ischemic changes. If the nerve is involved in the orbital fissure, superior orbital fissure or the orbital apex, then it would result in proptosis along with Horner's syndrome and cranial nerve 4, 5, 1, 5, 2, and 6 involvement. We localize in this patient, we localize the lesion to the right cavernous sinus because he has features of Horner's syndrome associated and severe pain. So it was a painful ophthalmoplegia with cranial nerve third involvement and Horner's syndrome. The differential diagnosis considered are infection, bacteria, tuberculosis, invasive fungal sinusitis, malignant infiltration, chronic granulomatous disease, sarcoidosis, immune-mediated IgG4 disease, vasculitis, cavernous sinus, thrombosis or tumors, or diabetes mellitus. The initial investigation, the routine investigations like CBC, renal function test, and LFT were normal. The inflammatory markers, ESR, CRP, were not markedly elevated. IgG4 was normal, so ruling out IgG4, and ANCA negative, ruling out vasculitis. Is normal, BPV is negative. Bone marrow examination showed non-specific trilineage hyperplasia with no significant abnormalities, and bone marrow culture was normal. So ruling out infections, and PET-CT also did not show any hypermetabolic focus, again ruling out infiltration or malignancy. However, it showed bilateral sphenoid and ethmoid sinusitis. A FES biopsy was done. A FES was done, which showed benign inflammatory polyps in right ethmoid and sphenoid sinuses, and a biopsy showed negative fungal elements, ruling out invasive fungal sinusitis. HbA1c was 7%, and he's a known diabetic. So diabetes is considered as one of the top differentials, and CSF analysis showed protein predominance with culture and expert negative. MRI brain with contrast showed thickened and enhanced dura of tentorium, pachymeningeal thickening with enhancement of the right oculomotor nerve. TB generally involves the leptomeninges. So in this case, again, it points more towards it doesn't support TB. I would like to discuss the cause of cranial nerve 3 before it reaches the superior orbital fissure. It divides along the lateral wall of the cavernous sinus into the outer pupillomotor fibers and the inner fibers. The pupillomotor fibers are supplied by the pial blood vessels, and it supplies the pupillary muscles. So if this outer fibers are involved because of compressive lesions like aneurysm or uncal herniation or a tumor, then pupils will be affected. And a term called lid gaze dyskinesis or a pupil gaze dyskinesis occurs when there is an aberrant regeneration of the damaged third nerve fibers, which results in The contraction generally, apart from the usual supply of the cranial nerve third, if the regenerated fibers supplies or innervates the lid muscles or the pupillary muscles, there is an associated contraction of the lid and pupil, and that would result in lid gaze dyskinesis or pupil gaze dyskinesis. If the inner fibers are involved, generally in medical lesions like medical conditions like diabetes and hypertension, then the pupil will be spared. In our patient, ruling out the infective, neoplastic, and infiltrative conditions, we consider a probable Tolosa-Hunt syndrome, and we started him on steroid pulse with IV methylprednisolone for 3 days, followed by injection methylprednisolone 500 mg in 100 ml NS over 2 hours, once weekly for 6 weeks, and planned for second-line agents during the OPD review. However, a possibility of diabetic cranial mononeuropathy also could not be ruled out. So a few points about Tolosa-Hunt syndrome. It is an idiopathic granulomatous inflammation of the cavernous sinus, which results in painful ophthalmoplegia due to the pressure on cranial nerves 3rd, 4, 5, 1, 5, 2, and 6. Diagnostic criteria for Tolosa-Hunt syndrome has sensitivity of 95% and a specificity of 50%. The criteria considered are unilateral headache, MRI or biopsy showing granulomatous inflammation of the cavernous sinus, ipsilateral cranial nerve 3rd, 4, 6 paresis, and headache associated with oculomotor paresis by less than or equal to 2 weeks with a headache with an ipsilateral headache. Symptoms not better accounted for by an alternative diagnosis. So the treatment considered, the treatment we give for the patient with suspected Tolosa-Hunt syndrome is IV prednisolone 80 to 100 mg daily for 3 days. Then we taper 20 mcg every 2 weeks once the pain resolves. This is a case report from PubMed which shows coexistence of Tolosa-Hunt with diabetic cranial mononeuropathy, like in our case, where Tolosa-Hunt syndrome and diabetic cranial mononeuropathy are considered the two top differentials. This is a study done in Turkey in 2014. Tolosa-Hunt-like syndrome in diabetes mellitus necessitates early initiation of corticosteroids and strict control of glycemic index, strict control of sugars will resolve the symptoms and will prevent the neurologic sequelae, especially in patients with cranial nerve palsies. And another case report where sarcoidosis, neurosarcoidosis is generally a rare presentation of sarcoid, which presents as a cranial mononeuropathy, also mimics Tolosa-Hunt's syndrome. Another case report where Tolosa-Hunt syndrome with spontaneous remission and recurrence. The case report of a 31-year-old lady in Spain with idiopathic right-sided facial palsy, and she had a spontaneous resolution of THS, which is not unlikely. Hence, we should suspect in patients experiencing an episode of self-limiting painful ophthalmoplegia and subsequent recurrence of symptoms. The learning points from this patient: anatomic localization of the 3rd cranial nerve palsy, and Tolosa-Hunt syndrome, which is a diagnosis of exclusion, and diabetes to be ruled out in any patient with 3rd nerve palsy, and early initiation of steroids with strict control of blood sugars. Thank you.
Thank you, Gladiss. What were the exact deficits of your patient?
Just had an isolated cranial nerve 3rd with pupillary sparing.
What were her eye movements?
It was a down and out pupil.
Okay.
With
the patient didn't have cranial nerve 4 and 6
no,
involved.
there were no other cranial nerves involved. But because he had a Horner's, he had a Horner's, we localized it to the right cavernous sinus.
Just go back to your presentation. Did you say it as minus -4?
No.
Was the pupil reactive? That's what I thought.
I had a drooping of
examination. Clinical exam, not just history. Go back to exam. Yeah. Pupils equal and reacting to. Sorry, I'm just looking at it.
Accommodation.
Why do you say it's accommodation?
Because he had drooping of eyelids.
What are the components of honors?
Anhidrosis, meiosis, enophthalmos, meiosis, enophthalmos.
And third nerve per se have ptosis.
Can just third nerve palsy have ptosis?
Yeah.
Yes?
Yeah.
Okay, so which part of honors did this patient have? Is all the deficits explained with just a third nerve palsy? It's okay. Is it a yes or a no? That's what.
Not completely. No.
Not explained. Which
No.
is not explained.
There's no meiosis or the other features of, apart from drooping of eyelids, no other features of honors.
So it doesn't look like honors, no?
Yeah.
No enophthalmos, no meiosis, no anhidrosis. Just the.
Yeah.
So it's like a third nerve, isolated
Isolated
nerve, rather than a honors.
Yeah.
So if you go back to your thing to say, okay, you had this difference, no, between go down. Yeah, you had explained. Just go down to the types of third nerve involvement. Just go down. Yeah, there you go. Pupils are spared. What do you mean by pupils are spared? Pupil is reacting to light. Yeah, and it's equal. So if pupils are spared, then what is it likely to be?
A diabetic.
So this is not a TOLOSA hunt because you're not having 4th, 6th, V1, V2 involved, right? It's not a honors with a third nerve. This is just a third nerve, probably related to that.
Yes.
I also would like to add, we cannot localize to cavernous sinus because it's only third nerve.
Yeah.
Because we localize to the cavernous sinus, which means actually 4, 6, and V1 of the 5th nerve also will get involved. So your localization is to the nucleus. Okay, here. And because pupillary sparing is there, it is probably a diabetic related third nerve palsy. So the most common nerves involved in diabetes are 6th and 3rd. So here the third nerve is not involved. The other issue is TOLOSA hunt occurs in middle age, not above 60. Commonly it's in a younger age group. Also, like, did you do ACE levels Manton because you mentioned neurosulfide as a part of the differential diagnosis?
ACE
That
is not.
was there in the investigation. ACE was not.
This is just a pure diabetes related thermal. You actually bring in honors to the localization related to
Does anyone have any questions? Yes.
I just want to ask the patient pain.
Yeah, he had
pain.
Yeah, he had pain.
Okay, just go back to the first slide.
So I actually wanted to ask, did you have like CRP
Headache.
elevated? Was there any high CRP markers of inflammation?
No.
Temporal
Temporal
artery.
Did
Did
you
you
look at
check?
the fundus?
You
Those were
checked
the other questions I had.
for nodules or?
We're just looking at a different set of differentials, which is why the question.
Yeah.
If no one else has any questions, we'll move on to the next presenter. Dr. Ritesh from Medicine 4, not too